to exceed your 4 minutes. We're already late. Okay.
Good evening, everyone.
Yeah.
I'll be presenting a case of a 38-year-old male farmer hailing from Belgavi, Karnataka, who presented to ophthalmology OPD with complaint of diminution of vision of right eye since 2 years. So the diminution of vision was insidious in onset and gradually progressive. The patient had a history of blunt trauma with to the right eye around 3.5 to 4 years ago. There was severe pain after the trauma, for which he consulted an ophthalmologist. He was told that the eye had blood inside, and he was given treatment for that, but there was no history of sudden decrease or loss of vision following trauma. The past history, personal and family history were not significant, and the general physical examination and systemic examination were within normal limits. Head posture, ocular posture, forehead creases were within normal limits. The uncorrected visual acuity was 660 N6 in right eye and 66 N6 in left eye. There was no pinhole improvement, and there was a decrease in contrast sensitivity by using Pelly-Robson chart. On retinoscopy, there was a faint glow in right eye while it was plus 1.25, but no subjective correction needed. The extraocular movements were full, free and painless. The adnexa was within normal limits. The conjunctiva and cornea and the anterior chip depth and contents were within normal limits. On gonioscopy in right eye, widened ciliary body band was seen, but there was no neovascularization of the angle. The iris, it was normal in color and texture in both eyes, and no NVI was visualized. Pupil, a single central reactive pupil was seen with no abnormality, reactive to direct and indirect reflexes, and no RAPD noted. The lens in right eye showed rosette cataract with an iris shadow. IOP by Goldman applanation done twice on the same day with a 1 hour gap was raised in right eye around 28 millimeters of mercury. This image shows rosette cataract in the right eye. This is the same eye with a history of trauma. Gonioscopic images of the right eye showed widened ciliary body band, widened CBB, suggestive of angle recession in all 4 quadrants, while in the left eye it is within normal limits. On distant direct ophthalmoscopy, a central opacity was visualized in the right eye owing to the rosette cataract. On disc evaluation, horizontal CDR was 0.5:1 and same vertical, and there was a temporal thinning of the neuroretinal rim, and there was nasalization of the vessels. On indirect ophthalmoscopy, the rest of the fundus was within normal limits. This is the fundus diagram of the patient, which I have represented with a increased CDR, and this is the fundus photograph of the patient with increased cup disc ratio in the right eye. Owing to the optic disc changes, HFA was done. A total deviation was in total deviation map. Total depression was noted, but this can be owing to the glaucomatous optic disc changes or to the cataract itself, so can't be conclusively said. We made a provisional diagnosis of middle-aged male with raised IOP with traumatic cataract and optic disc changes suggestive of open angle glaucoma secondary to angle recession. Now, patient was started on topical timolol maleate for control to medically control the IOP, and was followed up after 3 weeks, and it was noted that the IOP reduced to 18 mm Hg, and the patient underwent right eye SICS with rigid PCOL implantation. The surgery was uneventful. Post-op day vision was 6.9 and IOP was 16.8 by NCT. Post-op 1 week vision was 6/9, IOP was 19.2. Patient has been advised weekly follow-up for IOP monitoring, and OCT, ONH and RNFL and macula will be done to assess for any glaucomatous changes after 6 weeks post-op. Till now, the patient has not come for the 6-week post-op follow-up. So now angle recession glaucoma is a secondary open angle glaucoma that is associated with ocular trauma. So basically, some people might develop glaucomatous disc changes and vision loss days, months or even years later. So the mechanism is suddenly after the trauma, the aqueous will push the iris and the iris laterally and posteriorly. This might exert a traction force on the root of the iris, leading to a tear between longitudinal and the ciliary muscles of the ciliary body. this may be the reason of hyphema, as the patient was told, the patient had blood inside the eye. So this may damage the trabecular meshwork and the Schlemm's canal, leading to an early IOP swipe. However, long-term scarring and fibrosis of the trabecular meshwork or Schlemm's canal may lead to elevated pressure over the ears. Also, loss of tension over the ciliary muscles is another proposed hypothesis that causes narrowing of the Schlemm's canal. And also, in the long run, a hyaline membrane may form. So now, the key examination finding is widening of the ciliary body band, and this differential diagnosis should be made based on the time since injury. Early rise may be due to trabeculitis, iritis, hyphema, and trabecular disruption, while late may be due to angle recession, peripheral anterior synechiae, ghost cell glaucoma due to the dead RBCs, lens-induced glaucoma, or retained intraocular foreign body. So treatment of angle recession is similar to primary open-angle glaucoma. Topical equosuppressants, including beta blockers, carbonic anhydrase inhibitors, and alpha agonists may be used. Prostaglandin and analogs may be avoided in the acute phase, as they have pro-inflammatory effects. And eventually, trabeculectomy with the mitomycin has been shown to be successful in lowering the intraocular pressures. These are my references. Thank you.
Thank you.
So Ishan, I have a few questions from your presentation itself. You had iridodonosis. You have mentioned that there was iridodonosis.
Yes,
What do you expect with the lens? There was a rosette cataract, yes. Can there be something else?
Subluxation might be there.
How does it present as?
Subluxation will have phacodonosis also.
That should have been mentioned. But I really doubt that it was not there. So iridodonosis and phacodonosis have to be seen at different points of examination. One you see without dilatation, one you see with dilatation. Which one is what?
So iridodonosis without dilation, undilated patient, and phacodonosis.
Did you
with
check for
dilation.
phacodonosis?
Yes, ma'am. We checked for phacodonosis.
Okay, other thing, in gonioscopy, you have mentioned angle recession. Can there be some other finding? What else can be there in?
New vascularization of the angle.
No, in trauma, do you?
If in a long-standing,
It's not long-standing, right?
3 to 4 years, ma'am.
Okay, next.
Other than that, retained intraocular foreign body might be there. Generally, a blunt. This was
If
a
it's
blunt
a
trauma
penetrating injury, yes.
process. A
Next.
peripheral interior synechiae might have formed.
Okay.
And highly.
Can there be change in trabecular meshwork pigmentation?
Yes, ma'am.
Yeah, but it's not mentioned in your this thing. If there is a visible hyphema, do you do gonioscopy at that time?
No, ma'am.
How long do you wait?
Ma'am, I will wait for it to resolve first.
And immediately you'll do?
Ma'am?
Immediately will you do gonioscopy after resolution of hyphema? You wait for a week after resolution and then do, because there are chances of secondary bleed.
Oh.
There are a lot of other things, but we don't have time.
Oh.
Anybody else wants to ask?
No, invite the next speaker. I think they are also tired.
Right, thank you. Thank you, Shan.
And all of you, please don't leave the hall. Only 2 cases are left. After that, we'll have a group photograph with Professor Namta Sharma. For the first time, we started this PG capsule, and we'll continue this in future also. So you are the first batch. So we'll have a group photograph with you.
So,
Dr. Vibha, is
do we
there?
have Dr. Vibha? I would request the next speaker to be ready in the dais. Dr. Arushi, Dr. Vibha, Dr. Resham, Dr. Vanshika. Please be ready. Please be seated in the front row.
So Dr. Navdeep and Dr. Pankhuri are not there, right? Pankhuri, we call your name. You're gone for tea? Okay, we'll call you next.
Good evening, everyone. Myself, Dr. Vibha Singh. Thank you, AIOC, for giving me this opportunity to present myself at this platform. Today's case presentation is ocular hypertension post-phakic IL. It is a case report. 25-year female came to the removal of the spectacle. She is high myopic with spherical equivalent minus 14.50 diopter in right eye, in left eye minus 15.5, 255 diopter. Best corrected visual acuity in right eye is 6/6. Intraocular pressure is 10 millimeter Hg, and left eye it is 12 millimeter Hg. Central corneal thickness in right eye is 544 micron, and in left eye is 530 micron. Corneal white to white in right eye is 10.8 and left eye is 10.6. Anterior chamber depth is 3.59 in right eye, and left eye it is 3.65. The angle assessment using a ASOCT and OPT scan imaging was done. Preoperative angle assessment was done, so we can see it is 43 and in left eye, both eye it was in a normal limit. Considering the status, phakic refractive IOL was thus planned. Preoperative NDR laser iridotomy was done in both eye, implanted acryl phakic IOL as the number is just shown in a slide. Post-operative follow-up, post-operative day 1, IOP 2 hours after procedure, it is 18 millimeter mercury. After IOP in left eye, 2 hours after the procedure, it is 19 millimeter of mercury. Post-operative after 1 week, IOP was 12 millimeter of mercury and IOP in left eye was 12. After 1 month, IOP was 28 millimeter of mercury in right eye and left eye it was 26 millimeter of mercury. Vault height was 615 and vault height in left eye was 329 micron. So post-operative angle assessment was done. So we can see in the slide in both eye angle was within normal limit. So we have to think another school of thought. So there is some another underlying pathology which was causing increased intraocular pressure, IOP normal in immediate postoperative period, subsequently increase in absence of excess intraocular inflammation, excess ICL vault height ruled out by a ASOCT. So anterior chamber angle was open. IOP returned to normal 3 weeks after stopping the steroid eye drop. So diagnosis was made steroid responsive glaucoma. Differential diagnosis was missed primary open angle glaucoma. The optic disc in high myope usually tilted, large with a peripapillary atrophy, high myope predisposition to open angle and steroid induced glaucoma. Our patient has small eye as predicted with a corneal white to white measurement along with the high myopia. The chances of development of glaucoma increase manifold. So conclude the topic, identification of underlying cause of raised IOP. So crux of the management is treatment of underlying cause, retain viscoelastic, conservative treatment with anti-glaucoma medication or AC wash to remove the viscoelastic. If it is steroid responsive, stoppage or shifting to lower potency steroid, pupillary block glaucoma, enlargement of the iridotomy or surgical iridotomy. It was if malignant glaucoma, peripheral irido-zonulo-hyalido vitrectomy along with the AC reformation, explantation of the IOL filtration surgery are successful in controlling IOP in refractive cases. And take-home messages, if high IOP and still happy patient, rise in IOP detected earlier, treated promptly on every visit. Post-operatively, IOP measurement, angle assessment, and vault height measurement is essential. Extra careful with high myope and small eyes. Thank you. Yes. Central corneal thickness was 550.
Anybody wants to ask?
Meanwhile, the next speaker can get ready on the dais this side. We have Dr. Asmita. Do we have Dr. Asmita? Yeah. Please get ready.
Was it there in your presentation?
Yes, ma'am, it was in the presentation.
Okay. So other thing is your diagnosis was ocular hypertensive glaucoma.
Ocular hypertension. Well, ma'am,
No, you have mentioned glaucoma. Why did you mention glaucoma? That's not the diagnosis.
If the patient come with a high pressure, then first we suspicion of the glaucoma. If patient come with a high intraocular pressure, we just have a suspicion of glaucoma, ocular hypertension because angle was normal. It is only a steroid responsive and disc and all thing was normal. So we just
So Vibha, ocular hypertension is not equal to glaucoma. It's not glaucoma, right? And were there disc changes? Disc changes were there?
Not there.
So you cannot comment, I mean, you cannot label a patient as glaucoma. Glaucoma term has to be used only if the disc changes happen. So it was actually a case of ocular hypertension. It's not ocular hypertensive glaucoma, okay? Right, thank you, thank you.
Thank you.
Very good evening, respected judges. It's a case presentation. It's about a 44-year-old male patient who was presented in a glaucoma OPT, was referred from outside with the chief complaint of severe dull aching pain and redness in the right eye. He gave a history of cataract and rhegmatogenous retinal detachment surgery with silicone oil instillation in the right eye in June 2023. Also with a history of silicone oil removal of the right eye twice, that is on November 23 and again on December. The patient was on maximal anti-glaucoma medication. On ocular examination, it was found that the right eye best corrected visual acuity was finger counting 1 feet. The anterior chamber was deep Silicon oil bubbles were present. IOP was 32 mm of Hg. Gonioscopy was wide open angles with silicon oil bubbles were present. And on dilated fundoscopy, it was seen that the vertical cup disc ratio was 0.8. This is the anterior segment photograph of the right eye, where the slit lamp examination shows the silicon oil bubbles present in the anterior chamber. This is a gonioscopy finding revealing the silicon oil bubbles in the angles of the anterior chamber. The patient was planned for AMAT glaucoma valve in the right eye. These are few of the studies which shows that AMAT glaucoma valve implantation is much better in vitrectomized eyes. And the last study is about the amniotic membrane umbilical cord graft show is much better for shunt tube coverage. This is the surgery. We start by giving corneal stay suture, followed by conjunctival peritomy, then cauterization. The AMAT glaucoma valve footplate is implanted in the supratemporal quadrant, which is 8 to 10 millimeter from the limbus, and it's fixated to the sclera. Pilocarpine was instilled in the anterior chamber, followed which the tube was trimmed with the bend upwards. A scleral tunnel was formed. The anterior chamber was entered with a 23 gauge needle, and then the viscous elastic has been then given. The tube is entered into the anterior chamber, which was 2 to 3 millimeter from the limbus into the anterior chamber. The rest of the tube was fixed to the sclera, and it was covered. The exposed part was covered with amniotic membrane umbilical cord patch graft. Postoperative findings. The immediate postoperative was like the IOP was decreased by 16 to 16 mm of Hg, which was same even after 1 week. Here we can see the postoperative anterior segment photograph, which shows the AMAT glaucoma valve tube. So the take-home message is, in situations where trabeculectomy is not feasible due to conjunctival fibrosis, AMAT glaucoma valve implantation emerged as a viable and successful alternative for managing secondary glaucoma. Thank you.
Smita, so can you tell me other sites where the tube can be inserted in the eye? Other areas of the eye where the tube can be inserted? Here you have you done the case?
No, my process.
So here you inserted it in the anterior chamber?
Yes,
Can it be inserted anywhere else? So in pseudophakics, it's better to insert it in the sulcus, just behind the iris. So you do away with all the cornea-related complications, and it gives beautiful results. So I usually do it in the sulcus or in the vitreous cavity if it's a vitrectomized eye. And the silicone oil bubbles which you told about, where exactly, in which angle was it present?
in the trabecular mesh.
Must have been in the superior angle only. That should have been mentioned. So your picture also was of the superior angle. So you could have mentioned that, because the bubble will go up, right?
And
Thank
I
you.
think if the facility of ASOCT is available in your center, a post-op ASOCT again should be done to look for any cornea-related complications or to look for if the tube is rubbing with the cornea. Okay, thank you. Now next is Dr. Arushi. Pankhudi, okay, we have called Dr. Pankhudi now. Primary angle closure glaucoma with retinitis pigmentosa. Dr. Arushi, if you are there, please be ready for the next. Yeah, it is there, it is there.
This is yours?
Yes.
Okay, start.
Good evening, everyone. I'm going to present a case of primary angle closure glaucoma with retinitis pigmentosa. Prevalence of primary open-angle glaucoma with retinitis pigmentosa ranges from 2 to 12%, whereas prevalence of primary angle closure glaucoma in RP patient over 40 years of age is seen between 1.03%. Intraocular pressure elevation due to acute angle closure may aggravate the visual impairment in retinitis pigmentosa patients with pre-existing optic nerve dysfunction. Angle closure-related IOP elevation can be prevented by timely interventions in these susceptible eyes. A 34-year-old female presented with complaints of diminution of vision in both eyes, which was more in right compared to left, insidious in onset, gradually progressive, with symptoms aggravating in dim light or at night. It was associated with headache from last 2 days, severe in nature, not decreasing even after taking oral medication, and not associated with any diurnal variation. In ocular examination, the vision in right eye was 1/60, improving to 3/60 with pinhole. In left eye, it was 6/9. The pressure was at 10:30 a.m. In right eye, it was 38 millimeter of mercury, and in left eye, it was 36 millimeter of mercury. The cornea was clear in both eyes. Anterior chamber was shallow in both eyes. No AC pigments or cells were seen. The pupil was mid-dilated and sluggishly reactive. In lens, we found posterior subcapsular cataract was present in both the eyes. On fundus examination, waxy pale disc with temporal crescent, vertically dysmorphic disc, along with FR was dull, and severe arterial attenuation with bony spicules were seen all around in the periphery. Coming to the gonioscopy findings, in right eye, it was seen till 8 am with blotchy pigmentation in 2 quadrants, whereas in 2 quadrants, it was seen with till Schwalbe's line. In the left eye, it was in superior and inferior quadrant, ATM with blotchy pigmentation was seen, and in temporal and nasal side, Schwalbe's line was seen. On OCT RNFL, in right eye, all the quadrants were outside normal limits, except the superonasal quadrant. In left eye, only the nasal, temporal, and central we could see outside was normal limit. So left eye AIOC was done in the left eye. Vision improved to 6/9, and the pressure was 11 millimeter of mercury. After 1 month, right eye AIOC was done to control the pressure in the right eye, but the pressure was still found to be increased. It was still 40 millimeter of mercury. Then phaco plus trap plus was planned for this patient. Right eye phaco emulsification with PCIL with trap with MMC was done for this patient. On post-op day 1, the vision improved to 3/60 in right eye. Along with the pressure was under control, it was 13 millimeter of mercury. Cornea was clear, PCIL was in situ, AC formed, and bleb was visible. Surgical PI was patent. The previous theories regarding glaucoma in RP suggest that the migration of pigment is a characteristic features of retinitis pigmentosa, and these pigments in the angle of the anterior chamber has been stressed as possible etiological factor in the glaucoma. Ultrastructure of the lens in RP is altered, causing lens fiber disorganization, which may contribute to the instability of the lens with anterior displacement and narrowing of angle. Recently, zonular instability is speculated to be the cause behind angle closure in RP patient. Zhong et al.'s exploration using whole exome sequencing discovered the 5 genes CRB1, COL2A1, RHO, RP1L1, and PAC6 responsible for the genetic association between early onset BACG and RP. The predisposing factors for ACG in RP were nanophthalmos, cataract, lens subluxation, increased lens thickness, anterior segment dysgenesis, and short axial length. The take-home message was the tubular visual field might be observed in the patient of RP or PACG at the late stage. Therefore, atypical glaucomatous optic disc, similar visual defects, and the incidence of rarity may lead to a higher misdiagnosis rate. Hence, comprehensive ophthalmic examination, including gonioscopy, full-field ERG, macular OCT, and genetic testing should be done in younger RP patients in clinical diagnosis. Early intervention and maintenance of target pressure can control these kind of visual problem. Thank you.
Thank you.
Nicely presented, Pankuri. Okay, so the demographics that you mentioned, is it inclusive of the atypical RP as well? Have you read about it?
No, ma'am, only typical RP's
Sure.
article was present. I haven't
Okay. So
come
second
through it.
question is, why did you wait for PI in the right eye? You waited 1 month. The pressure was 40 in both the eyes.
Ma'am, the pressure was not controlled and cornea was not clear, so that's
So because the pressure is high, that's why.
yeah.
So why was it? Why did you
The
wait? Any
patient came,
specific
like,
reason
after
for it?
1 month only, so that's why it was done after 1 month.
So why was it not done concurrently?
Ma'am, in left
You don't
eye,
do it at the same sitting? Many people
same
don't do
setting,
it.
only unilateral it's done.
You do only unilateral at
Yes,
AIMS.
ma'am.
Okay. Right. Thank you.
Thank you, ma'am.
Now we have Dr. Arushi. She'll be discussing a case of restoring a lost globe post-trauma.
Good evening, everyone. I'll be presenting the case Restoring a Lost Globe Post-Trauma. So just a brief about traumatic globe dislocation. The globe is suspended within the orbit with suspensory ligament of Lockwood, the lateral and medial check ligaments, and it is supported by a bed of orbital fat. So post-traumatic large fractures can lead to the prolapse of the orbital tissue as well as the extraocular muscles into the adjacent sinuses. And in severe injuries with sufficient force to disrupt the soft tissue protection can cause the globe to herniate or subluxate. So we encountered the case of a 55-year-old male who presented to our emergency department with history of loss of vision in the left eye after fall from a ladder. The history dates back to one day where the patient lost vision in the left eye when he fell from a ladder while he was doing household work. No other remarkable ocular or systemic history was present. There was no loss of consciousness or ENT bleed present. On presentation, the visual acuity in the right eye was 20/30 with the unremarkable anterior and posterior segment examination. However, in the left eye, the patient was PL negative. We had no view of the pupil. The adenexa showed a repaired upper lid laceration with interrupted 6-0 sutures. The socket appeared empty and the UM could not be assessed. The globe was not visible and we had no view of the fundus. So summarizing the case was a 55-year-old male with a history of blunt trauma to the left eye with loss of vision with sutured laceration with the left globe absent. So we suspected either a traumatic enophthalmos or an enucleated globe. So we went ahead with investigations. A CT scan was done that gave us the finding of left eye enophthalmos with heterogeneous area of signal attenuation with fat stranding and hemorrhagic foci. The intraocular and the proximal part of the left optic nerve could not be visualized and the rest of the optic nerve was within normal limit. Our management was to start with IV levofloxacin 500 milligram for 5 days and IV methylpred was started and globe exploration with a team approach of an ophthalmologist and oral and maxillofacial surgeon was planned. So we went ahead with an orbital decompression with FES. A transconjunctival incision was given. Preseptal and subperiosteal dissection of the entire orbital floor was present and the contents were lifted and a titanium mesh was placed and it was fixed with the help of screws. So on the post-op day 1 of repair, the patient was still PL negative. The pupil was fixed mid-dilated with restriction in all gazes. The sutures were intact and the anterior segment showed a subconch hemorrhage with a sphincter tear, iris pigments on the lens, and the fundus showed a picture of a Percher retinopathy, which can be seen in this image. So this was 6 weeks post the repair. This is a composite picture. The patient was still PL negative, but there was lack of any enophthalmos. The ocular movements of the patient was there with mild limitation in the left upgaze and the left levo rotation. The fundus finding post 6 weeks was surprising. The blood trauma had now led to the occlusion of the terminal macular arterioles and it presented with a pseudo-Percher retinopathy. There was disc pallor, attenuated retinal arteries and paramacular retinal arterial occlusion was present. So Percher has been reported after indirect trauma such as head trauma, long bone fractures. Ours is a case of pseudo-Percher retinopathy following a globe dislocation. Once we reviewed the literature, we found that only 26 such cases of traumatic globe disluxation into the sinuses were formed, and unfortunately, 9 of them only regained complete or partial vision. Our present case fits into 2023, where blunt trauma led to this injury. The presenting and the final visual acuity was no PL, and we had given 1 gram of steroids for a period of 5 days. So none of the cases had any evidence of a direct trauma to the optic nerve and the retinal findings. So we hypothesized that the sudden shock waves, they converged on the posterior pole. There was disruption of the endothelium due to the sudden deformation. Platelet aggregation led to thrombus formation and arterial thrombosis and occlusion facilitated by local vasospasm occurred as a response to trauma. So our carry home messages, we are reporting a case of a rare traumatic globe dislocation in which the patient has regained cosmesis but no vision after doing the globe repositioning. CRA could be associated with blunt trauma and globe dislocation when the prognosis is visual. As we postgraduates are the first line of our emergency management, it is a rare scenario where prompt initial evaluation as well as interdepartmental collaboration in our case resulted in a good cosmetic outcome. Thank you.
Thank you, Dr. Arushi. How big was that orbital fracture?
Ma'am, he had a Leaford fracture 3 and the medial and the inferior wall of the orbit was fractured.
Okay, so what are the indications of immediate fracture repair? Like usually we wait for 2 weeks. So what is the indication of immediate repair?
Ma'am, in our case, the orbital...
I know about your case. What are the other indications?
Ma'am, if orbital nerve is involved, then decompression is urgently
Speak in the
required.
mic.
If enough, in case of enophthalmos, if the globe is not seen, if we are suspecting that the globe has subluxated into the sinuses, then urgent repair is required.
Okay. And also, if there is an entrapment of inferior rectus with associated vasovagal signs like bradycardia, then it's an urgency and you need to repair it as early as possible. Being an oculoplastic surgeon, I just have one thing. I think instead of taking help from the maxillofacial people, we should try to repair the orbital fractures with the help of oculoplastic surgeons. Thank you. Any more questions?
Nobody could hear you. You have to speak louder.
Ma'am, we are yet to publish this case.
Yeah, please, you can send it to IGO case reports.
Nice documentation also.
Thank you, sir.
Good evening, everybody. Today I'm presenting a case of a rare and successful management of pediatric Lyme injury during the COVID pandemic. Oculochemical burns are an acute ophthalmic emergency, alkalis being the more common agent at 60% of total oculochemical burns, commonest being live. Amongst the pediatric oculochemical injuries, the most common mode is bursting of tuna packets. Alkalis are more dangerous owing to the mechanism of action where they penetrate deeper into the stroma. Here we have a case of a 3-year-old female child who presented to the OPD with a right eye redness, pain, and watering since 7 days with a history of right eye accidental fall of line while playing with the tuna packet. There was history of consultation at a local clinic where she was given primary management in the form of ocular lavage and was subsequently referred. On presentation, patient had right eye vision at PLPR defective, and there was 180-degree limbal blanching with superior 1/3 deep stromal infiltration or deposit. Adjacent 2.5 to 3 mm of sclera also showed infiltration or deposit with a Duas grade 4 ocular burns. We took the patient for an urgent lamellar dissection with glycerol preserved donor CS rim, which was the only available tissue during the first wave of COVID pandemic. Patch graft and AMG was done under general anesthesia. On the top right image, as we can see, there was a chalky white substance in the superior 1/3 of cornea and sclera, which was dissected, revealing an underlying healthy DM and endothelium complex. Histology was suggestive of dried up tissue with fibrotic stroma and calcification, suggestive of Lyme deposits. Culture was negative. A graft was fashioned custom to the defect and sutured, and a double-layered AMG was done over the graft with fibrin glue. Corneoscleral infiltration post-ocular Lyme injury is a rare presentation with a likely diagnosis of retained Lyme particles. Present case was managed timely by debridement, glycerol-preserved CS graft, and AMG to enable future visual rehabilitation. At 8 months of follow-up, the patient had visual acuity which improved to counting finger 1 meter with vascularized CS graft with superior mild symblepharon with chances of future visual rehabilitation. After 12 months of primary surgery, cadaveric simple limbal epithelial transplantation was performed, and post-op day 15 of which there was visual acuity which improved to counting finger 3 meters. During the COVID pandemic, there was a delayed time of presentation of the affected patients, explaining the late presentation in the present case. In time where eye donations were far and few, timely use of available resources like a glycerol preserved CS graft in conjunction with AMG preserved the tectonicity and provided therapeutic purpose where visual rehabilitation could be planned. Timely management in cases of a chemical injury is critical. Immediate intervention in forms of lavage, debridement, AMT, tenal plastic can exponentially increase the chances of visual rehabilitation. In a meta-analytical study conducted by Clifton et al., it was seen that patients with timely surgical intervention were found to have greater visual acuity, shorter epithelial defect diameters on follow-up, greater reduction in limbal ischemia, and possibly preventing the need for a future slit. In a study conducted in Western India, it was also noted that there was significant visual improvement and corneal vascularization was to a lesser extent, which encouraged performance of an AMT in early phase. Take-home messages are, even in times where fresh corneas were not available, use of techniques like AMGs and tectonic grafts from glycerol-preserved donors can provide a good emergency alternative. Chemical injuries, especially Lyme, are fairly common and necessitate a timely management, which can often be site-severe. A proper primary management is critical and should be undertaken even in absence of facilities.
A lavage, proper debridement, and timely intervention can protect patient prognosis. Examination of pediatric patient can be especially challenging, owing to lack of cooperation. Should always be done with double eversion, and GA or sedation should be considered. Thank you. These are my references.
Thank you. And wonderful done surgery. COVID was a difficult time for us. We were struggling with corneal tissue, and at our center also we used glycerin tissue a lot of time. And yeah, that was the right approach. Whenever there is chuna particle, you have to remove it. If you don't remove it, the eye will go into thysis bulbi because of the slow release, and continuous inflammation. And so final was finger count half meter, you said, right?
3 meters, sir. So actually, we do not have, the patient has not come after the final follow-up.
Anyway, at times we feel that 3/60 is not a good vision, but if you see the outcome of chemical injury patients, right, 3/60 is still a good job, right? Because we have seen patients' eyes going to thysis bulbi. The injury was severe, as I can see. So in this patient, the chances of thysis bulbi is quite high. Perfectly managed cases. Now, any comment from the panelists?
When was the patient lost to follow-up?
So
Now or there, I mean, just
at
after the
15
surgery?
days, the last follow-up we had was 15 days post-SLET, which was counting finger 3 meter, as I mentioned. After that, patient has been lost to follow-up and has not yet come.
So I just wanted to ask you the current age, but then you're saying the patient,
Patient was
because
lost
you
to
have to
follow-up.
manage amblyopia also in such patients. And you have used the terminology of infiltrate. I don't think that's correct. Superior corneoscleral deposits. Infiltrate means infective, right?
Yes, ma'am. Actually, we were suspecting, we couldn't, that's why we even
Infection.
went for histopathological examination of the deposit. So we wanted to rule out any infective etiology.
I think your patient might be doing good only. That's why he has lost to follow.
So the patient might be doing good. So
Let's
this is a
do
good, valid explanation.
Do we have Dr. Vanshika? Thank you, Resham. So last call for Dr. Navdeep and Dr. Vanshika. No?
Okay, so we'll have a group photograph, as I have put that in the group. So we are waiting for Professor Namta Sharma to come. Once he comes, then we'll take a photograph. I request all of you to come forward. And AV team, videography team. So how can we take a good photograph or video? आप एक बार आगे आ जाइए, चेयर पे बैठ के कर लें या स्टेज पे आ जाएंगे सारे? So ma'am, Dr. Namta may take 2-3 minutes to come here. So so this is the program which me, Professor Namta and Dr. Anu Malik, we conceptualized. Okay, let's do something there where we are going to ask the student to present. Most of the conference is only the faculty who has already spoken on the same topic since last 2 years. He or she will come and he will speak on the same topic. So rather than that, we thought let's give a chance to our own PG students. Okay, so then they will present and we'll just discuss. We will not take any faculty lecture. कहाँ से लेके? वीडियो कर लो और हमारे मोबाइल पे ले लेना, है ना? हाँ, भूपेंद्र। आप लोग आगे आ जाओ, यहाँ हो जाएगा ना वीडियोग्राफी। Still भी आ गया ना? All of you please come forward.
This is neuro, squint and neuro.
फोटोग्राफर जी बताइए कहाँ पे खड़े रहेंगे हम? पूरे आएंगे सारे।
ऊपर आ जाते हैं, बैकग्राउंड आ जाएगा ये।
And thank you all of you. When we planned this program, I was not expecting 100 plus case presenters would come, and it was really awesome to get all those case presentation from you people. And we were like changing rules, asking PDF, and all of you followed all these rules strictly. Thank you for that. Thank you for tolerating us.
जाए. I would like to thank and dedicate this program to Dr. Namrata Sharma ma'am, our chairman scientific committee. Case presentations have provided the best peer and self-evaluation today. Much appreciation to Dr. Namrata Sharma ma'am and Dr. Praful sir for this dynamic show and tell activity. We look forward to more presentations and participation in the coming years. Thank you.
নেক্সট ইয়ার আমি কোথায় গেল? সৌরভ কোথায় গেল? এই আমার একটা পোডিয়াম ঠিক আছে, নিচে চলে যা, নিচে চলে যা। সৌরভ সৌরভ পোডিয়াম, না না তুই ওটা এটাই লেখাটা নিয়ে ভাই, প্লিজ 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 না প্লিজ। এই সর্বরাজকে একটা দে, সর্বরাজ সর্বরাজ প্লিজ নে না, নিচ থেকে এই ও ও 1 মিনিট ভাই, 1 মিনিট আমি তুলবো, আমার তোলা হয়নি তখন। হ্যাঁ 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 লে লে লে। আমরাও আছি, হ্যাঁ চলে 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 চলে